Well, really excited to be here this afternoon. So I will be talking about the implementation of remote symptom monitoring using patient-reported outcome measures. And I thought what might be really interesting is really also presenting the project, but also how we learned about implementation science and how we're now trying to really use that moving forward. And I kind of just, stumbled upon implementation science. It wasn't part of what it's a relatively new science, and when I did my PhD or even my postdoc, it wasn't something we talked about in terms of implementation science. I don't see the square around my slide. Do you see my slide? Yeah, okay, perfect. Okay, so the main clinical challenge that we are trying to address, my team, is the patient symptom burden in oncology is underestimated. And this is really well represented by the curves that you see here. So the blue curve represents the number of patients reporting a certain symptom when we ask them. And the orange curve represents the number of patients that clinicians report having. Sorry, it's the opposite. The orange curve represents the number of patients reporting a symptom, and the blue curve, the number of patients that clinicians report having that same symptom. And so what we notice is that the orange curve is always above the blue one. So there's always more patients reporting a certain symptom than there are clinicians thinking that that patient has that symptom. And what we see also is that the difference between the orange and the blue curve gets wider with symptoms that we might not see as observable, right? So fatigue, it might not show that you are fatigued. Same thing for other symptoms that we can consider maybe more subjectives. And so we know there's a lot of literature that underestimating patient symptoms can be burdensome for the patient. Obviously, their quality of life, they might miss work, they might have to miss treatment, cancer treatment. And also in terms of return to the emergency room, these patients are much more likely to seek healthcare in terms of, or their greater use of healthcare services. And so there's potentially a lot of solution to this clinical challenge. The one that we've been working on is using patient-reported outcome with the primary hypothesis that this difference that we saw in the previous curve is due to a lack of communication regarding the symptoms. In oncology, the clinic visits, well, and I think in every department, I have young kids, and at the children, it's also 10-15 minutes if I get that. Clinic visits are very, very short. The focus is on, especially on oncology, on treatment. Does the lab results? Does the treatment need to be changed? What's next? What's the progression of the cancer? And there's not necessarily a lot of discussion in terms of the symptoms. So our solution, patient-reported outcomes. What are patient-reported outcome measures? It's a measure based on a report that comes directly from the patient about the status of their condition without interpretation from the clinician. What is a patient-reported outcome measure? This is an example that we use in oncology. The Edmonton Symptoms System Assessment Scale. And so we've used the ESAS for decades. There's a lot of research on this scale, whether a 3 is clinically significant from a 0 to 10 scale. Maybe 3 is significant for pain, but it's not for nausea. Like, we just have a lot of psychometric studies that have been conducted. And so this one, we call it, it's a goodie. It's an oldie, but it's a goodie. There's other PROMS in oncology that are taking more and more popularity, but I need the confidence that when I say to a clinician, look, we'll develop an algorithm based on this, and I'm confident that a 4 on 10, it's safe to say to the patient to wait 24 hours, as opposed to it's no longer safe as a 6 on 10, right? Because that's still what that represents. And so there's a lot of literature in terms of the efficacy of PROMS. We know that PROMS can help you identify symptoms earlier. They improve patient communication. They improve patient satisfaction regarding their care, because during the consultation, we talk about what's most important for patient. They save time. There's a learning curve to use PROMS in clinical practice, but they also save time because we focus on what is most important, what is most urgent in that 10-15 minutes. As opposed to then patient maybe saying, oh, I forgot, calling back the clinic, trying to reach the, so there's a time, but there is a learning curve in terms of trying to use these PROMS. They improve symptom management. If they improve symptom management, they lead to better quality of care and better quality of life, and also can lead to reduced health services utilization and increased survival. And so as we move from strong, consistent evidence, where it's green on the continuum, there's weaker evidence for increased survival, but more and more we have randomized control trials showing us that there's an increased survival. So when I present these results, I'm often told, yes, this is great, but real world is much more messier than randomized control trials. So what do we know about real world implementation of PROMS in oncology? Well, Cancer Care Ontario has been implementing the ESAS across the province since 2007. So they're starting to have a really nice database of looking at the results of patients that were screened with the ESAS versus those that were not screened. And here what you see on the graph is the ESAS screening in terms of ED rate visits. And so what we see is that patients that were screened with the ESAS are less likely or have fewer emergency room visits. And this is among women with breast cancer. But they've been analyzing and sub-analyzing with other cancer patients, and they're noticing the same thing. So the dotted line is patients that didn't have the ESAS and their return to emergency room visits, and the full line is those that didn't. But implementing PROM there's a lot of considerations. Who responds to PROMs, when, what is the frequency, which services are available to respond. That's the first thing I'm asked when we approach a new clinic and ask them to do PROMs. Like, if you start detecting more symptoms, I have to respond to them. And so I might not have the services to respond to those PROMs. Which PROMs do we use? There's a lot of discussions about which PROMs, and then how do we deliver them? Electronically, paper. If we do them electronically, there's not one cancer center in Quebec that has the same platform. Well, actually, cancer centers do not have a patient portal. The MUHC did have one, but none of the other cancer centers have a patient portal. And so right now we use we use Qualtrics, which is a survey platform. And so the goal of eImpact, which is electronic implementation of PROMs across Quebec, was to have a large deployment. There's 31 cancer centers. When we started this in 2017, we're like, no problem, let's go to like 10 of these. Just, spoiler, we made it in 3. But and blood, sweat, and tears. So I'm actually really happy how we ended up, because it almost fell apart completely. But the large deployment, again, think about those previous evidence that I showed you, right? Like right now in oncology, we are no longer in a situation where we're doing randomized controlled trials to establish efficacy. We are really in a real world implementation and sustainability, because we know this can really have an impact for patients. And so eImpact was funded by the Canadian Partnership Against Cancer in 2017-2018. It was a 5-year project, and it involved 49 clinicians, managers, researchers. We started across 7, it went up to 10, and then we're back down to 3. But as you see, we had HMR, Cité de la Santé, the MUHC was a very close collaborator, St. Mary's Lakeshore, and the SHUM. Believe it or not, we started this conversation in 2018, and the SHUM were just about to start our implementation, just to tell you, 8 years or 7 years later. But if one key message, like persevere, like if you fail first, try again, right? So this is the overview of the components of eImpact. So eImpact first starts when we send the questionnaire, the PROMs, like the one that I showed you previously, electronically. And like I said, because patient portals there's none really available, we had to think of a plan B. And so we're using Qualtrics. We send a link via email to patients, and they click on the link and they complete their PROMs. At St. Mary's, we use an old technology called DART, so patients do it in the waiting room on a tablet. But mid-project, we get a call. This is DART comes from Ontario. We get a call, and Ontario decided they were decommissioning DART within the next 2 years. So then we had to also turn around. Yeah. So using technology has its, it's supposed to be a facilitator if you have the technological infrastructure. And right now in Quebec, we don't, but that's okay. We turned around. We're putting St. Mary's on DART as well. So patients complete their PROMS. We coded an algorithm behind that says, if ESAS 2 on this symptom, whether it's mild, moderate, or high. So the clinician gets a report clearly saying, these are symptoms that we consider based on decades of research on these PROMS, that this symptom is low, moderate, or high. And the patients also get a summary report. Before I got into PROMS, I was a lot into self-management and patient empowerment and, how they can learn from a day-to-day to cope with cancer in the best way possible. And so normally PROM programs don't include this patient component, but for me it was really, really important based on our previous research. So patients get a summary report. They get the same data as their clinician, but interpreted in a way that they can easily understand. And then depending on if symptoms are mild, moderate, or severe, then there's different clinical pathways that are undertaken. For mild, moderate, we favor self-management. So they get fact sheets that clinicians across all the centers have approved. And for severe symptom, the clinician gets alerted. In the meantime, the patient also gets, but there's an alert that is triggered. How that alert is triggered, who it is triggered to, varies per center. And then patients have access to a self-management resource library. And then so we hope that by the patient having a report, like the main mechanism of action is again this communication pillar. Because the patients have their data, clinicians have the data, we hope that then there's a better communication, better clinical follow-up, and better symptom management. There's one randomized control trial that has been done that looked at no PROMS, PROMS where the report goes to the clinician, and PROMS whether the patient only receives the report. Both PROM groups were better than the no PROM group, but there was no difference between whether it was just the clinician that got the report or if it was just the patient that got the report. So meaning that both were better though than none. Right? So this came after we designed this portion of eImpact. It's a recent trial that came out. I was really, really happy to see this because it gives even more evidence base to this component, giving patients, and then we also send to patient a sheet that says how to communicate your PROMs to your clinicians. So because a lot of patients will be like, well, I'm scared if I arrive with my report and during my clinical appointment, maybe my clinician will get mad at me. Maybe he or she won't like that. Maybe they'll see me as difficult. So we give them a sheet. And say, do not worry, and we give them tips, you bring your sheet and we have a scenario in that sheet. You bring your report and your oncologist says, what, I don't have time to do that. How do you then respond? And so so you'll see, I think our efforts are paying off. I do have some effectiveness data. So our resources are free to use, whether you participate in eImpact or not as a clinical site. Some clinical sites don't even have basic fact sheets for help patients manage symptoms. So the website actually gets a lot of traffic because some centers don't have that yet. So really what eImpact is trying to do is establish a culture of measurement in oncology. So we have like a core algorithm, and then we devise sub-modules for each cancer type. We have a module for caregivers. We have a module more for survivorship. So these are all different grants actually that we got that we're able to then build this program. So when people come to us, then we say, okay, we'll take the core algorithm, and you're doing it with breast cancer, so we'll take this module. So we were able to recruit 250 patients, but this is like, it doesn't seem like a lot for the number of years, but given Dan, you're laughing. But given the technological infrastructure of our system, I'm really excited that we got to 150. I couldn't be more happy. So we had what we called a prospective longitudinal quasi-experimental mixed method designed to evaluate real-world implementation. So we are in effectiveness evaluation here. And so we have a baseline, a pre-implementation survey that we give, and then patients completed their PROMS for 4 months, and then we have a post-implementation, and we have a control group that we were able to recruit. But it was very hard to recruit the control group because centers did not want to participate in the control group. Because the evidence is so strong for the PROMS, they didn't want to waste time. Again, like, I don't know if you see me, but in major quotation, despite explaining to them the purpose of a control group, they were like, no, we just need to know whether we're able to do this, whether we're able to do it well, and whether we're able to sustain it. So again, I just want to say that prior to eImpact, I did mostly clinical trials. And so when I started real world, I was like, I just want to go back and do another RCT. Like, they're clean, they're like, you know, they're rigorous, and it's my clinical trial team that was working on this. My coordinators were like, Sylvie, like, what are we doing here? This is so messy. Since then, we've learned that, you know, messy is where we live and where we thrive. But at the beginning, it wasn't fun for none of us. So I'll share with you, though, you know, I'm being a bit of a downer here, but I'll share with you some of the findings. So patients perceived a lot of benefits so here we interviewed participants. In addition to the survey, we also interviewed them, and we had satisfaction surveys and all of that. So patients perceived benefits. Generally satisfaction was actually quite high. It did vary per center depending on the platform that they use. Some platforms were just very complex. It kept on logging you off. You had to log back in, Patient really did not like it. Our adherence rate was 80%, 85% in some centers, whereas other centers was 65%. And when we asked patients why, it came down to the technology being used. But generally, we made everything like very easy to access, very, you know, like they say in the quote, everything was at your fingertips, one click away. Patients, when they submitted their report, they got a message with links to the self-management, like everything was one click away, as this participant said. What we really liked is that it did establish the main mechanism of action of establishing better communication seemed to have been met. Patients said, you know, it's that establishing that extra line of communication, even if it is virtual, like they felt the data was being sent to the clinician. However, if the clinician did not talk about the PROM results during the consultation, adherence went way down. So I do it once, you don't talk about it. Okay, I'll do it twice, you still don't talk about it, forget it. Like, what's the point, right? So so we would tell patients, like, the clinician won't say, I saw your eImpact results. Because talking to clinicians, they say, yeah, I use it, but they integrate it, right? So it's not necessarily obvious to patients that they're using the data. So we definitely help patients, like, develop materials to explain to patients, saying they might not say it, but they are using it. There is nothing that will replace a good conversation about your symptoms with your clinician. But the second best thing was definitely the self-management resources. So they were developed with patients, for patients, validated by clinicians. So that was definitely worth the time. And the summary report as well was generally appreciated, where patients could see the trends in terms of their symptoms. It's not for everyone. Sometimes for patients, completing PROMS is actually anxiety provoking, because I have a big list of 15 symptoms, and you're wondering why you have none. Does that mean the treatment is not working? You're in oncology here, right? The treatment is not working. I'm not getting affected by it. It's not affecting the cancer. Or the opposite, you know, I wasn't thinking about my cancer for, you know, the past 3 days. And then you keep on bombarding me with PROMS, which is every week. So it's bringing me back constantly to think about my cancer. I don't have a break from it. So this is causing me anxiety. But these are some of the perceived benefits. In terms of our satisfaction survey, overall we covered the right symptoms. It did not take too much time to complete for most patients. 55% consulted the summary report. You can think, oh, that's a bit low. It is a bit low. I would like to get it higher. However, this was self-directed. There was no prompts from clinicians. Patients don't do anything until, most patients prefer their clinician to tell them, go and see your report, bring your report. I'll be happy to see it. If that's not done, then you get the portion of patients that are self-directed, that do it, which is not everyone. And also that most patients felt, those that did use it felt that it helped them understand. And again, the fact sheets, only 50% of patients looked at the fact sheets, but again, self-directed. Then we worked with clinicians. When we saw that it was 50%, we developed a pamphlet that clinician can give to the patient and say, I approve. Like, we realized the extent to which patients really need the seal of approval from their clinicians to use anything that is seen like exterior to the clinical encounter. But those that did consult them, they learned something from the fact sheets and learn new ways of managing their symptoms. In terms of clinicians, generally what they really liked about it is that while patients are on clinical trials for new drugs, they do PROMS, and clinicians are aware of the PROMS. But once the clinical trial is done, the PROMS are taken away. So they felt it was a very powerful system that mimicked when patients are on the clinical trials. It was well integrated into the care process. We spent a lot of time mapping, like patients arrive at patients are diagnosed with cancer, then what happens? Then what, like the clinical process without the PROMS, and then inserting within the clinical process the PROMS, and that eventually paid off. And we were happy to see that not a lot of clinicians, we're still interviewing clinicians because they're very hard to get to interview. Those that we did interview felt that it optimized their appointment time. This is preliminary results, but it looks like we are having an impact on symptom severity. So patients that were on e-impact generally report lower symptom severity than patients that were not on e-impact. And also we are looking at survival data, and it looks at patients that were on e-impact have a higher survival at 6 months than patients that were not on e-impact. So not trivial as an intervention, but this is very preliminary. We're still looking into our data, getting the data. So I'll just go quickly in terms of barriers. I've named quite a, there was a lot of barriers and facilitators throughout the implementation of e-impact. A lack of technological infrastructure I've named. Some clinicians were like, I do this already. So then you have to work with saying, well, no. I do this already, so I don't need PROMS. And then so, showing the evidence and competing projects. There's always a lot of projects that different settings are doing. So how do you then give priority to PROMS versus smoking cessation program versus and then there's no services available to respond to the PROMS. But this just summarizes a bit what I've been talking about throughout. There's barriers for clinicians, but there's also barriers for patients. And maybe I was a bit naive at the beginning because I didn't expect barriers for patients. I only expected barriers for clinicians. But when we started giving the PROMS and patients were saying, well, I don't have any symptoms. I don't need to complete this. I'm not sure if my clinician will accept this. It's a lot of work. I don't understand. I don't have the literacy. I couldn't click the link. It's anxiety provoking, like I said, this long list. And these are things I did not expect from PROMS. And we did have a patient partner committee. And this was not raised during the patient partner committee meetings because the PROMS were obviously developed with patient partners. And that wasn't, but then that's happened when you're in real world, right? Like everybody does it, no matter your demographics. We're trying to get everybody to do it. So some of these things come up. And I said, some patients stopped their PROMS after clinicians didn't respond. So I'll just stop there because my presentation kind of has two parts. The part is like the project, and then my second part is a bit more about implementation science because we kind of forgot that part that we're actually implementing a project in a system that is already overstretched. So maybe, I'm doing good for time. So maybe, if I can take a few questions on the first part of the presentation in terms of the actual program before I go any further.
I have a question. Sylvie, you talked about those red, yellow, green, mild, moderate, severe symptoms. How did you decide, on what basis did you decide what's mild, what's moderate, what's severe?
Yeah, 100% based on psychometric data that have been done on the ESAS. So if I take anxiety, for example, there are a lot of studies that have asked patients to complete the anxiety item on the ESAS, and that these patients have also completed diagnostic interviews with psychologists, and then they look at sensitivity and specificity.
Right.
So the gold standard being the interview, and they have found that generally a cutoff of 3 on anxiety is clinically significant. So for me, that 3 was moderate, 3 to 6 was moderate, and then depending on the sensitivity and specificity data that I have, then 6 plus was considered severe. And so we have that for the ESAS for a lot of the symptoms. We have a gold standard comparing the ESAS, and then based on sensitivity and specificity data, I'm able to then give a cutoff.
Were you able to adjust or manipulate that in real life based on the data that you got? Like, was within your implementation, was sensitivity and specificity what you wanted, what served you,
Yeah.
or not? Were
Yeah.
there red lights, not too many red lights, ta?
Yes, so that's really interesting. So we're still analyzing that data. So in terms of whether there were too many or not, the alerts, we haven't analyzed that yet. But what we have done, and we just submitted the paper last Friday, is that we've replicated the sensitivity and specificity with our cutoff points in our sample for right now, just for anxiety and depression. But we will, for the ones we have a gold standard. So our gold standard is not a clinical interview. It's a more specific scale that was always also given for anxiety and depression. So the GAD-7 and the PHQ-9. So we started and we replicated the same thing, a cutoff of 3 for anxiety and a cutoff of depression of 2, which was good news for us. But in terms of, the number of alerts, did clinicians feel the alerts were useful or not? That's very messy data, and we're still looking into that. Yeah. Yeah, Monse. Oops, sorry.
Hi. On the exact same slide, actually, that the Dr. Ponor is asking about, you mentioned that you summarized the data first, and then, like, basically summarize the prompts, and then you basically divided them into 3 classes. First of all, how did you summarize them, and then why only 3 classes?
Yeah, so we summarized them by graphs. I wish I put a screenshot of my of the summary report. So we have so it's graphs that we have, longitudinal graphs. So each time they have a PROM, we map the result on the graph. So the 0 to 10, and so then they see how their symptoms over time evolves. And on the graphs, there are like the cutoffs are indicated, right? So the cutoff for moderate is clear, there's a yellow line. The cutoff for red is there's a red line. So patients are able to follow and clinicians, whether the symptom increases in severity or decreases in severity or is stable over time. So it's all graphs. Yeah.
And the decision to only go with like basically green, yellow, and red, I think it was just like a standard, like basically approach to follow, right?
Sorry, can you repeat the question?
So you had only 3 classes, I'm
Yes.
curious to know like why 3 classes? Why not like more? Like how did you come up with like basically that cutoff?
Yeah. So again, it's mostly based on previous studies done with the scales that we're using.
Mhm.
So it's true that we could have done, you know, mild, moderate, like mild slash moderate, moderate slash severe, severe to, but again, that has been done for some of the scales that we use in our algorithm, like the ESAS is one of a couple of scales. And psychometric studies previously have found that having more of those categories did not lead to a clinical advantage, whereas those three categories generally do. So that's why we did it that way.
Okay, I see. Okay, thank you.
So I'll shift a little bit the presentation. So that was e-impact. It's, you know, it's implementation.
We have another,
Oops.
we have another question in the room. Sorry to interrupt.
Sorry, I was just wondering if, because if you're administering the PROMS throughout the timeline, if the patient doesn't improve in a certain aspect or if they remain at the same level, is the recommendation given to them the same throughout, or is there a time factor also taken into consideration?
Yeah, that's a really, really good question. Right now, the time factor is not so much for the patient, it's more for the clinician. So the patient would be given the same recommendation. It's not tailored to the fact that, hey, we gave you the exact same recommendation and there's no improvement. Right now, with the technology that we have, like that would be difficult to implement. But the clinicians, that they wanted to know, because what we learned over time is that they don't act on at one point in time. So let's say the patient, we might send an alert of 6. They might not do anything at that point in time, but next time that there's a PROM and it's again a 6, then that's when they would act. So on the report, it was important for them to have a summary page that says this symptom has improved, this symptom has worsened, and this symptom is stable. So, but not the patient. But that's a really good point. So I'll shift a bit gears and we'll see where we get. But I thought it would be really interesting, given some of your lab's work, to talk a little bit more about implementation science, because we're implementing PROMS in a context, in a healthcare context, that is really overstretched. No joke, in 2017, when I started presenting this project, like we had managers get up and leave the room because for them it was just not conceivable for them to implement yet another project. Then 2020 happened, and 2021 and 2022 and 2023. All the waves, all the, you know, were each time a wave was crashing, we're like, oh, we're never gonna get this project done. And so, and our funders weren't backing down, weren't saying, oh, it's okay. You know, they were really pushing. The Canadian Partnership Against Cancer had as a goal Canadian-wide implementation of PROMS. So again, implementation science is a relatively new science. So initially when we started this project, my background, like I was saying, was RCT, psychometrics. So I was very focused, okay, what's the measure? You know, when are we gonna give it? And then I realized that over time, what was more important to the clinicians is the how are we going to do this? So less the what and the why, which is what I presented in my first part of my presentation, but more the how. And I had a clinician that stopped me in one of these presentations, very similar to the first part of my presentation, after the slide where I said, well, the solution is PROMS. She stopped me and she said, I don't need another presentation on PROMS. Like, I know these work. I need you to tell me how I get my patients tomorrow morning without creating burden on my team. So this is all about the how and implementation science. And so slowly I became very interested in implementation science, which is the scientific study of methods to promote the uptake of innovations. And like I said, it's a relatively recent science. It's not something that was covered when I did my PhD. It wasn't covered when I did my postdoc. So I can't, well, like again, that time is going by, but I just kind of wanted to plan to, you know, depending on your different projects and whatnot, that this is an amazing body of literature that really, the way that I see it is implementation science is my toolbox. And there's different tools within this, different methods that I can use to help me. And the implementation tools that I wanted to introduce to you today is, choosing an appropriate theoretical framework to guide the implementation science process. Choose a framework to assess barriers. You'll see that initially our assessment of barriers wasn't very thorough. Sending a survey based on a theoretical framework to assess barriers and select implementation strategies. So I'll just quickly go over each one of these, and happy to answer questions or follow up anybody that is interested. So in terms of a implementation science framework, this is, again, an oldie but a goodie. I've looked at different ones, and we are using the action cycle of the knowledge to action framework. And this framework has two parts to it. So the blue one and the blue part in the middle, and the gray squares around. The blue part in the middle is all about when we create knowledge. So all of the systematic reviews I presented to you before, for PROMS, it's very, very strong. But it says once your blue part is strong, you need to get into implementation. So that's what we focused on, is really the gray parts. And so this is referred to as a process framework in implementation science. And when you're starting an implementation process, an implementation project, you can get lost. And I hope that I gave the impression that I did get lost throughout e-impact. And sometimes I didn't think I was going to get back on the road. I really thought I was lost for good. And you need to tether yourself to these kind of frameworks that tell you exactly step by step. Those gray boxes are a step-by-step process of how to approach implementation. And I just want to touch upon very quickly how we, once we discovered this framework, how we kind of went about this different steps. Can maybe just a show of hands, anybody knows the KTA framework, is aware of this framework? No. So, so the first part is to identify the problem. So once you want to do an implementation project, you identify the problem, determine the gap, and identify the knowledge that will help you address this gap. We did not have a choice. The Canadian Partnership Against Cancer said, we are implementing PROMS across Canada in cancer care. We have all of those systematic reviews. So when we approached the centers, there was no discussion there. We just went ahead. But then we had to adapt to local knowledge, which is your second step in this knowledge to framework. So we had the pillars of the impact that I showed you, but all of these different pillars needed to be adapted to the specificities of each of the cancer centers. So the green shows that everybody used the same questionnaires. Everybody approached it this way. And actually one of the questionnaires, the ESAS, was also dictated by the funding organization. So you have a bit of a top down, right? We say, well, okay, we have money to implement PROMS, but there are some restrictions. We have to use the ESAS, but then the rest we can adapt. So for us, what was important, but then people say, well, then you're comparing apples and oranges. What NUHC did is not the same thing what the SHUM did, and what the SHUM did is not the same thing as St. Mary's. So in implementation, I think you have to be comfortable that you have to tailor this to different centers. And when we're evaluating the components. So when I showed you the data on the impact, I'm evaluating that if I give you a questionnaire, if you have a summary report, if there's a risk, but then the minute details did vary across the different centers. So we did have working groups across the different centers to be able to adapt the knowledge to the different, so we had an education working group. So we wanted, for example, for constipation, the recommendation is the same across all centers. And I'm laughing a little bit because the number of conversations I had about whether it's 8 glasses of water or 10 glasses of water for constipation is more than I ever wanted. But this is important because I had some clinical teams say, if it's not what we do already, we're not doing this project. That's the implication, and the clinical response. We do this, or we send to the ER if it's 38.3 fever. We send to the ER if it's 38.5 fever. We sent, we tried to standardize across all the centers, which required a lot of discussion. And then you need to assess the barriers and facilitators to knowledge use. We thought we did a good job, but you'll see that we didn't do a good job. But this is what we did initially. Initially, we had a launch for e-impact. So we all got together face to face, and initially it was 7 centers. So all represented from all 7 centers, we got together and we had a launch for e-impact, and we asked them to complete a barriers and facilitators survey that my team put together based on previous experience. What are the advantages of PROMS according to you? What are the challenges? And we thought that, it was a decent survey. And what we found is that some centers were already using PROM data. Most of them was pen and paper, and few centers said that their patients are sufficiently engaged in managing their symptoms. So again, that helped us to determine that, yes, self-management resources might fill a gap. And then examples of barriers were limited resources, integration within the clinical flow, and high patient volume. Especially big centers like the MUHC and SHUM, they were thinking, if I have 500, 600 patients, on this system, like how many, we were saying, Dan, how many will actually be alerted? Like 10%, 15%, 50%? Imagine if 50% of your patient volume is being alerted. Like, you can't do that, right? That's not feasible. And then we selected what we refer to as implementation barriers. So implementation strategies. Implementation strategies are what you think will help in the implementation process. So we had money. Every center had resources that we provided. That was not a problem. We had a site coordinator for daily troubleshooting. We had champions. We had a central coordinator, full-time. We offered continuing education sessions. We provided credit from le Collège des Médecins. So clinicians that came to our information center and didn't feel they were wasting their time. Name it, I think we had it, really. But still, we were having trouble with implementation. And what we realized is that what I presented to you in terms of barriers and implementation strategy, we did what felt right, but it wasn't really anchored in evidence. And this is when we discovered implementation science, and this is when I realized we didn't do steps 3 and 4 very well. So mid-project, I said we have to stop, we have to look at the implementation science methods, and we actually have to go backwards to better be able to move forward. And so we went back and we realized the knowledge to action framework gives you the steps that you have to go through to implementation, but then within each step you need more frameworks. So my second tool is choose an appropriate framework to assess barriers. And this is the one right now that we use, the SAPHIR, the Consolidated Framework for Implementation Research. And look at all the barriers. When I saw this, I thought, oh my God, I'm okay. Like, I'm not completely going crazy over trying to implement this thing. Like, this for me was like, I don't know, it was like therapy when I read this, because I was like, okay, this is why I've been banging my head for the past 2 years. And so our mistake that we had a process framework, but we didn't have a determinant framework to really be able to say, okay, these are the problems. Remember before the oncologist that told me I don't want another presentation? If I had assessed that setting before, I would have known that they had high buy-in, but they were lower on other barriers. So the SAPHIR has 48 determinants of implementation. And this is also really good. Anybody interested in implementation science, it's a really, really, really good paper. It tells you the different frameworks you need to really try to implement. We had a process framework, but then I realized we were lacking a determinant framework. And for us, the SAPHIR is the one we use. And so then my third tool is to evaluate the barriers based on the determinant framework. So then what we did, the SAPHIR has a really good website, and you can get tools that match each of the determinants So then we developed actually a tool. So for every 48 determinants, there's one question assessing it. Our first barriers survey had like 10 questions. So this way we have 48. And the so what is that when we started using this survey, we realized here, like, you know, in terms of the first part in green, that's the buy-in. So it told me right away that buy-in is not an issue in this setting. What's the issue in this setting is that people don't know what their roles and responsibilities are. They don't know the described tasks and timelines. So instead of during that hour teaching about why, and you know, and that's what we typically do, right? We implement, we do it in service, we say why this is important, we present the project. I missed the mark completely. It was roles and responsibilities, never covered that in my presentations. So that's the power of having a good determinant framework and then being able to measure it. So I see time is going by. So like my last tool is implementation strategies. And again, there's a framework called the ERIC framework that exists. I have a QR code here. If, after that, you can have the presentation. But if you click on the QR code, it'll describe like 50 implementation strategies. And the idea is that when you have a certain barrier that you identify, like mine was roles and responsibilities, the evidence now is mounting that if that's your barrier, then this is the implementation strategy that's the most efficacious. So as opposed to doing what we did before, let's just throw everything in there, and it probably will have an impact on some barrier of some sort. Now you're being much more thorough and systematic in matching your barrier with your implementation strategy. And I don't think I have time to present this, but again, there's a QR code. There is a tool that exists where you can select your barriers. So is the video moving for you? Yeah, okay. Oh, it's not working very well, huh? I guess my internet might be a little, I'll try it again. I can send this to your, to Dan, and maybe if you want to send it, I'm happy. But oh yeah, it is working now. So what you do is that you select your barrier, and then it tells you which are the implementation strategies that you should be using with the level of evidence that you should be using it. So if we take the barrier that I was talking about earlier, wait, is it clicking for you? Are you seeing it okay, Dan, or do you see it with the delay? Okay. So if we take the barriers that, for me, that wasn't so much of an issue, like in terms of the buy-in and in terms of the evidence, you can see that it's a lot of the implementation strategies that we did without knowing that that's what we should be doing. Like that's the key issue here, and that's the problem that we did. So of course, the buy-in and the why was very good on my survey afterwards, because without knowing, those were the implementation strategies that we did. But if you look at then, my issue was roles and responsibilities. Remember on the previous slide of the survey? Well, when I put that in this tool, it tells me that it was something completely different. And the implementation strategy I should be using is something called an implementation blueprint, which I didn't have, which makes sense then that that's what came up as being a problem. So you can play around with that tool. Again, with the QR code, it'll bring you directly to the Excel sheet that you can use, and you can play around with the different barriers and facilitators. So again, I discovered this, like, you know, these are not things that I was aware of when I started. I wish I was aware, and now I don't do anything without following the 4 steps that I shared with you today. So I'm just going to stop there. So my 5 recommendations for a successful implementation project is define the what, the who, and the why, which was the first part of my presentation, you know, and your questions were about why the cutoffs, and that's okay, but recognizing it's only the beginning, and most of the time is spent then on implementation, on how you're on the how and your implementation, and grounding yourself in key implementation science tools. So a process implementation framework, so your knowledge to action framework, and then your barriers and facilitators framework, and then matching your barriers using the tools that I presented with your implementation strategy, not overusing tools, right? Because if we overuse tools like training in a So there's certain things that'll work out well, but then you're not addressing potentially barriers that will cause your project to crash. E-Impact is still alive. Like I said, I have some centers I've been trying to implement for years, and then 2 weeks ago got a call and saying, we want PROMS now tomorrow. And I was like, oh, okay. Oops, sorry, so yes, but then that doesn't match. We don't have core funding, so we're going from grant to grant to grant. So what I've learned is that with implementation, you need to try to stay alive for a long time, which doesn't match the typical 3 years, you do a grant, you have objectives, you move on, you know. So we've had to be creative in terms of sustaining, so that when centers are ready, then we're able to expand the way we wanted to. So that's that.